day, fellow learners. Once again, here's your Mentor Ray. I'm a test preparations coach for the past 25 years, more than 25 years actually, and I'm focusing on test preparations related to NCLEX. It's my personal mission in life to assist as many nurses as I can. This is my way of giving back for the blessings I had. And thank you for giving us that opportunity to serve our frontliners at this point who would want to turn their great American dreams to reality. So, welcome to QuickFix Session 13. So, once again, we will be dealing with the most requested topic, which is prioritizing and delegation. And before we begin, let me ask for your help to join me in this mission. Our goal is to provide free NCLEX RN application and review to 100 nurses. We've assisted so many of them already. They have passed, they've taken the NCLEX, and thank you so much. And for you to continuously doing that, those of you, hundreds of you who already passed their NCLEX, please do not unsubscribe. Keep on watching our videos, and so that you can help us achieve our goal to help at least 100 nurses to apply and pass the NCLEX RN. Okay? You could also try to hit the subscribe and bell notification button and then share our video to at least 3 of your friends. We're gonna pray for you that you will shut down the NCLEX at the minimum item of 60 and pass the test. So to help us achieve this goal, just watch and finish the ads in our videos. That would be a great help. That's the only thing I'm asking of you in exchange for what we're doing right now. This is my personal mission to help you achieve that dream. I know you're aspiring for that, and let me be the instrument to help you out achieve your dreams. Okay, so if you have questions, and for the answers to the questions I will post, because I will be raffling again 5 sets of the Ray Gapos system learning tools made up of your nursing reminder sheets and of course your NCLEX 311. The international title, you can have it in Amazon, is NCLEX RN in a flash. Okay, NCLEX 311 is the Philippine title of my book. Okay, so you have the 311 most common functional concepts, the question, the rationale, and of course some pointers. Okay, so let's keep the ball rolling. Before we begin, let me greet one of our passers, Marian Buenaflor of Lorma Colleges, USRN, for passing the New York Board of Nursing last December 29, 2020. Congratulations. I love the picture. It's very artistic. So, congratulations, Marian Buenaflor, ng Ilocano na imbag nga aldaw yung amin dita apo. Okay? I'm also a GI, genuine Ilocano. Alam mong mga gaposes from Luzon, Visayas, Mindanao. Pero ang aming roots talaga ay sa Nagilian, La Union. Yan, marami kong mga pinsan dyan sa San Fernando and Rosario, La Union. Okay, so congratulations and thank you for the trust, Marian. So here's an advice from a QuickFix participant, one of our QuickFix participants, from K. Rodriguez. Really thankful that I found Gapos. Uploaded videos are really helpful. Please keep on posting videos about NCLEX. Yes, I'm doing that regularly, twice or thrice a week. The only time that I don't post the video is when we're going to have QuickFix session. Okay, and we're gonna have QuickFix sessions regularly. Don't worry, I'm not gonna stop this until all of the Filipino nurses out there and some of our friends from the other countries, all of our friends from other countries will pass the test with minimum number of 60. So hit that bell subscribe notification button now. So NCLEX lectures and tips for us to pass the NCLEX exam. Stay safe and God bless. Thank you for that wish, K. Rodriguez, and my pleasure to be of service to my colleagues, especially the frontliners. This is my way of sharing my God-given knowledge. At this time of the pandemic, I was thinking, what can I offer my colleagues? And I thought about helping you out, turn your great American dreams to reality. Okay, whether you're a frontliner in the Philippines or somewhere else in the world, you are actually part of God's mission to preserve life. That's a very godly mission, right? Okay, so for those who have yet to check on our YouTube channel. You have Gapos Mentors, and we have several videos, short ones that deals with the pointers and long ones that discusses the entire process. We also have QuickFix session number 1, which is approximately 2 hours. If you would notice, we're now on session number 13. Okay, so those of you who may want to check on our videos of ECG, we have short ones for the pointers and long ones for the comprehensive discussion of all the disorders that are frequently covered, okay, in your test. And of course, if you may want to request PDF files of the copies of the slides, we could gladly send it to you through email. So please do send us a message. Okay, so let's begin our QuickFix session 13 by answering a sample question. Here we go. This is sort of like a vague type of question because you have a very concentrated stem, and then the options are just merely words or phrases. Okay, so while assessing a client, let's read through it, who was previously diagnosed with hyperthyroidism, the nurse notes tingling around the client's mouth and the fingers. The nurse should consider as a priority to ask the client about. So you have here a diagnosis, okay, and that was previously. At this point in time, the nurse is having tingling around the client's mouth and the fingers. And this could mean that there is a complication. So what could that potentially tell us? So if you have a patient who is usually hyperthyroid and then they have the goiter, then eventually they undergo thyroidectomy, there's a potential that the parathyroid glands could be removed during the surgery. And we all know for a fact that the parathyroid glands, okay, helps maintain the balance of calcium through the hormone parathormone. So if the parathyroid glands were accidentally removed, the secretion of parathormone will be affected. Therefore, eventually, when parathormone decreases, calcium decreases, hypocalcemia results. The initial manifestation would be tingling around the client's mouth and the fingers, and then eventually patient will have Trousseau sign, and then Vostek sign, in which you percuss the facial nerve. That could lead to the facial muscle twitching on one side where you percuss the facial nerve. So what should we need to inquire to a patient who is having symptoms of hypocalcemia? Is it about the neck surgery, the diet, thyroid medications, or genetic disorders? The answer? Definitely it's about the neck surgery. That's your thyroidectomy. So remember, numbness and tingling around the mouth and the fingers and toes indicate hypocalcemia. So this is your Vostek sign. This is your Trousseau sign. Okay? So let's go back to the sample question. Our answer here would be neck surgery. So if the patient has had thyroidectomy, so that could potentially have led to the accidental removal of the parathyroid gland that could have brought the manifestations that the patient is suffering from. So let's try answering a sample question. Here we go. Here's another sample question. But before you move on to that, okay, when we speak of hypocalcemia, one important thing that I'd like to highlight is that you have to know the normal levels of calcium and pay particular attention to the unit, because the normal value would be 4.5 to 5.5. Some literatures would have 4 to 5.5 milliequivalent per liter. Okay, and then when they have the normal value at 9 to 10.5, the unit is usually milligrams per deciliter. So you have to be conscious what unit is being used. If it is milliequivalent per liter, that's going to be 4 to 5.5. Some literature have 4.5 to 5.5. But for the unit of milligrams per deciliter, they usually have it at 9 to 10.5. So if I were you, I'll just memorize 1. So I'll memorize 4 to 5.5, multiply that by 2. That's the approximate normal value when the unit is changed to milligrams per deciliter. Okay. Now, the amount of calcium usually affects the functioning of 3 main organs. Okay. The brain. Okay. Because your calcium helps to carry impulses from the brain to the different body parts, okay, specifically to the muscle, so it could also affect muscle movement. The blood, so it facilitates clotting, and the bones. Definitely, it helps maintain bone density. So it's very important that when your patient's having hypocalcemia, you have to provide calcium-rich diet. And this would mean encouraging the client to eat milk, yogurt, cheese, green vegetables, and of course, tofu. Tofu has approximately 800 milligrams of calcium per serving. And take note that per day, we need 1,000 milligrams of calcium approximately. Okay, if the patient gets pregnant, you add 200 milligrams. Okay, so for the pregnant client, they need 1,200 milligrams of calcium. So you need to actually give them additional sources of calcium to meet the recommended dietary allowance. Okay, so let's now move on to this question. A client with thoracic spinal cord injury is admitted to the unit. Assessment of the client reveals the following. Blood pressure of 110/60. What's the pulse pressure? The difference. So 116 minus 60, that means 56. So the pulse pressure is widened. Widened pulse pressure could be associated with increased ICP. Pulse is 62, that's still normal, within 60 to 100. Respiratory rate is 12, that's still normal, 12 to 20. Arterial bicarbonate, 29 millimeters mercury. Okay? Yeah, that's supposed to be milliequivalent per liter. Sorry for that. So arterial bicarbonate, okay, the normal is 22 to 26. It's a little elevated. Arterial pH 7.20. The normal is 7.35 to 7.45. That's decreased. Arterial carbon dioxide is 54. So carbon dioxide, the normal is 35 to 45 millimeters mercury. And arterial pressure of oxygen, that's 75 to 100 millimeters mercury. 85 is normal. So there's no problem with oxygenation such that the patient is retaining carbon dioxide. So what do we need to do? So client is retaining carbon dioxide, the blood pressure is the pulse pressure is widened, so the client is having increased ICP plus retention of carbon dioxide. Those are the problems. Now let's answer the question. Which nursing intervention should be the priorities of the nurse? Okay, to answer that question, you have to have functional concepts. Like in clients who are retaining excess carbon dioxide and with widening pulse pressure, the priorities are assess the airway and promote a patent airway, position the client properly, implement deep breathing and coughing exercises to get rid of excess carbon dioxide. So if we go back to that question again, okay, do we need to elevate the client's head? Yes, to prevent further increase in ICP. Even if the client has spinal cord injury, yes, you need to elevate the head of the client. And then implement coughing and deep breathing exercises. Yes, to get rid of excess carbon dioxide. Assess airway patency. Yes. Connect the client to a ventilator. Yes. Provide a detailed explanation of the client's rehabilitation plan. This is about discharge planning, and this should not be taken while the client is having increased ICP. So that is an X. Deal with that when the client is about to be discharged. Okay? Here's another one. In the care of a client with tumor in the adrenal medulla, the highest priority of the nurse is which one of the following interventions? Now, what is challenging with this question is that you do not have a diagnosis, but you have a description. You have tumor in the adrenal medulla. What should you think of? Think about pheochromocytoma. Now, pheochromocytoma is a benign tumor of the adrenal medulla. Now, what do you need to think about the adrenal medulla? The adrenal medulla is responsible for the secretion of your catecholamines, specifically your epinephrine and norepinephrine, which are responsible for the fight and flight response. Now, the byproduct of your catecholamines, when they are metabolized, you have your vanillyl mandelic acid. Okay? That is why the initial test that's done for clients with tumor in the adrenal medulla or pheochromocytoma would be to gather a 24-hour urine specimen to measure the amount of vanillyl mandelic acid in the urine, because normally the amount should be 2 to 7 milligrams per 24 hours. If the amount of vanillyl mandelic acid goes beyond that, that could mean that there is increased secretion of epinephrine and norepinephrine. And since when these hormones, or epinephrine and norepinephrine, are responsible for the flight or fight response, it could potentially lead to hypermetabolism that results to what is termed as adrenergic crisis. So in adrenergic crisis, the vital signs go up. We focus on the blood pressure because hypertensive crisis could result. And when you say hypertensive crisis, the BP goes up above 180 to 120. Therefore, the priority for a client with adrenal medulla would be to monitor the client's blood pressure. So to answer that question, you need your functional concepts. Pheochromocytoma, a tumor in the adrenal medulla, can potentially cause hypertensive crisis. If you know this concept, it's easy for you to identify blood pressure monitoring as your priority. Remember, what occurs in pheochromocytoma is contained in the code 5H. What are the 5H? The first one, there's headache. And then there's high blood pressure or hypertensive crisis. Then there's hypermetabolism. Then there's hyperglycemia. And then there is hypercalcemia. So these 5H occur in pheochromocytoma. So let's go back to the question and let's answer. In the care of a client with tumor in the adrenal medulla, the highest priority of the nurse is which one of the following interventions? Is it recording the urine output, number 1? Number 2, obtaining serum glucose levels? Number 3, monitoring the blood pressure? Or number 4, maintaining a high sodium diet? The answer, monitoring the blood pressure. Okay. So, let's try answering another sample question. Wow, I love this question actually. A patient comes into the emergency department showing the skin discoloration on his flank as shown in the picture below. Okay. The nurse documents this using which of the following terms? Now, what if you have a sample questions like this? But of course, they don't have the clue coming from the source of the picture, Creative Commons, okay? When you have the bluish or purplish discoloration in the flank area, this is termed gray Turner's sign. Okay. Cullen's sign is bluish discoloration around the umbilicus. Homan's sign is associated with thrombophlebitis. Okay. Macewen's sign is associated with hydrocephalus. Macewen's sign is a crackpot sound that is produced when you percuss the head of a baby or a child with hydrocephalus. Okay. Okay. So, here's a functional concept. Gray Turner's sign is associated with intra-abdominal and retroperitoneal bleeding. So take note, intra-abdominal and retroperitoneal bleeding. So it could be behind the peritoneal area. Okay? So this is how we differentiate the signs of peritoneal bleeding. You have Cullen's sign or the sign that occurs in intraperitoneal bleeding. This occurs in clients with ruptured ectopic pregnancy. Okay, or this also occurs in clients with pancreatitis. Okay, Cullen's sign. Okay, then you have Gray Turner's sign that occurs in retroperitoneal or intra-abdominal bleeding. Okay, so the difference, if it occurs in the periumbilical area, Cullen's sign. If it occurs in the flank area, Gray Turner's sign. Okay, you have your purplish discoloration of the skin. So this is your Cullen's sign. This is your Gray Turner's sign. So, Gray Turner's sign can be found in which of the following conditions? Remember the concept? It's found in intra-abdominal and retroperitoneal bleeding. Could it be found in ruptured abdominal aortic aneurysm? Yes, there's bleeding. Splenic rupture? Yes, that's in the abdomen. Ruptured ectopic pregnancy? Yes. Perforated duodenal ulcer? Yes. Hemorrhagic ascites? Yes. Perineal hematoma. Okay, the perineum is not in the abdomen. Okay, what happens in perineal hematoma is that you have swollen bruises under the skin, and this is due to a burst blood vessel. So a blood vessel that has been damaged, okay, and it needs to be drained. Why? Because it could cause severe pain, bulging, and in some cases, bloody stools. Perineal hematoma could result to the presence of bloody stools. So in perineal hematoma, the intervention could be application of cold compress or sitz bath twice a day, and then the use of donut rings, okay, to decrease pressure on the hematoma, increase fiber in the diet to prevent constipation, and instructing the client to avoid strenuous activities. So the patient may not go lifting weights. So once again, perineal hematoma is not related to Gray Turner's sign, so we put an X. Okay, perirenal hemorrhage. Remember, the kidneys are located retroperitoneally. What did we say a while back? That Gray Turner sign could be associated with retroperitoneal bleeding. So in perirenal hemorrhage is bleeding, then we could expect Gray Turner sign. So we put a check. I just hope you're learning from what we're having right now. Here's another one. So while changing the client's position, the chest tube of the client is accidentally removed. Which of the following interventions is the highest priority of the nurse? Is it 1, to auscultate for breath sounds? Is it 2, to reinsert the tubes immediately? 3, notify the physician? Or 4, apply a sterile dressing and ensure tight seal. Now, to answer the question properly, you need to have a functional concept, our hero. So remember, the priority when accidental removal of the chest tubes occur is to cover the chest tube insertion site with a dressing that is taped on 3 sides. Now, why are they advocating that we tape the dressings on 3 sides such that it prevents the entry of air into the system, preventing pneumothorax, but it would allow for the exit of air? That's the reason. But sometimes they advocate the use of vaselinized gauze. Okay. So the answer, therefore, is to apply a sterile dressing and ensure a tight seal. That is the priority when a chest tube is accidentally removed from the client's chest. Okay. So here's another one. While suctioning the endotracheal tube of a 10-year-old client, the nurse notes that the client's heart rate decreases from 98 to 56 beats per minute. Which of the following interventions is the highest priority of the nurse? 1, document the incident as an expected outcome. 2, administer epinephrine IV. 3, continue suctioning until the procedure is completed. 4, stop suctioning and reconnect the child to the ventilator. Okay, to be able to answer that question, you need again functional concept. Remember, acute bradycardia during suctioning can be associated with the stimulation of the vagus nerve. So you have your vasovagal reflex stimulated. It can potentially lead to hypoxia because the bradycardia will decrease the activity of the heart, and there's going to be decreased supply of blood, leading to decreased supply of oxygen. That's why hypoxia could result from bradycardia induced by suctioning. Therefore, if we go back to the question again, while suctioning the endotracheal tube of a 10-year-old client, the nurse notes that the client's heart rate decreases from 98 to 56 beats per minute. Which of the following interventions is the highest priority of the nurse? The answer, stop the suctioning and reconnect the child to the ventilator. Okay, here we go. Here's another sample question, this time in a client admitted to the hospital for sickle cell crisis. Which goal of care is considered the highest priority? Once again, the magic phrase, highest priority. So 1, prevent infection through administration of antibiotic. 2, facilitate urinary elimination through the insertion of a catheter. 3, to maximize hydration through insertion of intravenous fluids. 4, to promote rest through the administration of a narcotic. Now, to answer this question properly, you have to know what's happening in sickle cell crisis. Sometimes sickle cell crisis is called painful crisis. Okay? So, in sickle cell crisis, maintaining hydration is a priority as it reduces the viscosity of the sickled blood, preventing the development of thrombosis. Because the problem in sickle cell crisis, the sickled blood could become C-shape or S-shape, and then they cling together. They form a thrombose that could lead to CVA, and that could obstruct the blood vessels. So thrombosis can develop. Okay? Now, take note that your sickle cell crisis affects commonly the 3 main parts of the body. Remember, A, B, C. The arms, the bones, specifically the spine, okay, the arms and the legs, the bones of the arms and legs, and then C, the chest. So the arms, the bones, the chest. A, B, C. Okay? So when the sickled RBCs clump together, they potentially block the blood vessels in those body parts, leading to the presence of pain. So sometimes over-the-counter medications like ibuprofen would be enough to manage the pain, but in severe cases, you would need to administer a narcotic. So pain management is definitely a priority. Apart from that, to decrease the viscosity of the blood, you have to ensure and maintain adequate hydration. And to do that, you have to initiate intravenous fluids administration. Okay? So therefore, the priorities would be pain relief and intravenous fluid administration. So using that knowledge, let's answer this question. In a client admitted to the hospital for sickle cell crisis, which goal of care is considered the highest priority? Is it 1, to prevent infection through administration of antibiotic? 2, to facilitate urinary elimination through the insertion of a catheter? 3, to maximize hydration through insertion of intravenous fluids? And 4, to promote rest through the administration of a narcotic. And the best answer would be to maximize hydration through insertion of intravenous fluids. What is wrong with number 4? Because the administration of narcotic is not intended to promote rest but to manage the pain. So remember, if a part of a possible answer is wrong, the entire option becomes wrong. Okay. Now, let's move on and focus on the prioritizing concepts related to seizures precautions. But better way to do this but to answer a question. Here we go. A client suddenly begins to have a seizure while he's lying on bed. Pay particular attention to the context. So the client is not on the floor, the client is on bed. Which nursing actions are, keyword, contraindicated? You are not being asked to identify appropriate interventions. You are being asked by the question to identify inappropriate interventions. So select all that apply. Turn him to the side. Okay? Is that appropriate or inappropriate? That's appropriate, but we put an X because what is being asked would be the one that's contraindicated. Okay? Try to interpret the question properly. This question is very prone to misinterpretation. Try to force a bite stick into his mouth. This is contraindicated? Yes, that's why we put a check. Okay? This is very confusing, right? Okay. Restrain the patient. We don't restrain a client in seizure, so restraining is contraindicated. So the question is asking for something contraindicated, so we put a check. Loosen restrictive clothing. Take note, loosening restrictive clothing, okay, is indicated. So it's not contraindicated. So we put an X. Let the pillow remain under his head. Now this is where the problem is. So the client is on his bed. Remember, putting the client on a flat surface that with the head in a soft device, like for example a small pillow or a folded clothing, would be appropriate to protect it while the client is having seizure. But the client is already on bed, so we do not need to have the pillow. So is that contraindicated? Yes. So we put a check. Okay. So in seizures, the two main priorities would be promote a patent airway and promote safety. How do we promote a patent airway? Turn the client to the sides, loosen tight clothing. If he stops breathing or turns blue, gently position him on his side to open the airway and prevent the backward falling of the tongue, which may obstruct the airway. To promote safety, do not hold someone down during a seizure. Protect the head with something that is soft and flat. Do not forcefully insert anything in the client's mouth. And remove hard or sharp objects from the area. Notify the doctor immediately if the patient is having aspiration of vomitus. Okay, now a lot of people are asking and they have requested me to discuss defense mechanisms. So to some people this could be very basic, but remember, the coverage of the test on the NCLEX have a very wide range from the basic to the advanced. So let's begin. Here are, okay, the things that we need to remember for defense mechanisms. The most common defense mechanism would be denial, the failure to acknowledge an intolerable thought or feeling, okay, and this is normal, okay. So denial is found in alcoholic patients too, okay. In schizophrenia, the most common defense mechanism in general is regression, a return to an earlier stage of development in the face of stress, which means the patient could actually assume a childlike curled position in bed. That's a form of regression. Or bedwetting when you are under stress. That's a form of regression. But take note, there's a certain age that you have to pay particular attention to whether to label the bedwetting as normal or related to regression. Remember that nighttime bladder control will not be mature enough until the age of 5. So you expect children 5 years old and below to wet their beds, and the intervention is to just change the linen and make no issue or fuss about it. Okay, so for daytime bladder control, they achieve the control at age 2. Okay, so for children below age 2, they frequently wet their diapers. And that's the reason why when we are toilet training, we always begin with bowel training at age 15 to 18 months. Because that's the first thing that they're able to control. And then daytime bladder control could be achieved at age 2. Nighttime bladder control until the age of 5. Okay? Paranoid schizophrenia, there's projection attributing to others one's unconscious wishes or fears. Catatonia, that's repression. Okay? So repression is unconsciously forgetting intolerable experiences. Okay? In mania, you have reaction formation, expressing the opposite of one's real feelings. Remember, manic patients are deep inside depressed, but what they're showing is that they are hyperactive to cover up their real emotion. For depressed, introjection, the taking into oneself a loved or a hated object, and this usually leads to suicide. Okay? Anorexia, suppression or intellectualization, consciously suppressing their appetite. Anorexia nervosa is actually a misnomer because anorexic patients have appetite, only that they suppress it, or they use intellectual concepts to avoid expression of real feelings. That's intellectualization. Obsessive compulsive disorder, undoing. Okay, now an example of undoing would be hand washing, frequent hand washing. If you stop the obsessive compulsive patient from utilizing undoing as a defense mechanism, they eventually would develop increased anxiety. Okay, so undoing is their means of coping with repetitive thoughts and actions. Okay, next, phobia, displacement. Okay, turning an emotion to a less threatening object or subject. So, for example, okay, if you are faced with fear that you cannot confront, okay, you displace that fear to an object that could represent or take the place of what triggers your fear. So, for example, if you are fearful of being bitten by animals, then you translate that fear into fear of dogs. So you have phobia. You displace that fear. Okay? If you have fear of low scores, and then you displace that to the fear of the number 13, triskaidekaphobia. So you displace the fear. That's a form of displacement. Okay? Now, alcoholism, you have 4 defense mechanisms. Denial, rationalization means justifying. Isolation is emotionally detaching from a situation. So you're able to tell your story without emotions. That's isolation. And of course, projection is attributing to others one's unconscious wishes or fears. So for alcoholism, you have denial, rationalization, isolation, and projection. Okay? So let's try answering a sample question. Which of the following defense mechanisms are commonly utilized by an alcoholic client? Select all that apply. Rationalization, yes. Projection, yes. Isolation, yes. Remember the D in the DRIP acronym should be denial and not displacement. So we put an X on that and we put an X on undoing. Okay. So also, I'd like to highlight the concept of body mass index. Okay, although I've covered this in our past QuickFix sessions, please do just recall and how to differentiate it. Body mass index is used to determine proportion of weight to height. Your BMR, basal metabolic rate, is used to determine the rate of body's oxygen utilization at rest. So remember the formula of body mass index: weight in kilograms divided by height in meters squared. Okay, so the normal BMI would be 18.5 to 24.9, and then you are overweight if the BMI is from 25 to 29.9, obese if it is from 30 to 34.9, severely obese from 35 to 35.9, and morbidly obese if you have a BMI of 40 and above, I would like you to focus on the BMI range and how to interpret it. So a patient is obese if the BMI is from 30 to 34.9. Okay, so now let's move on to another requested topics. Okay, the prioritizing concepts related to phototherapy. Now remember, phototherapy is an intervention that is implemented in babies who are exhibiting jaundice. Now let me provide you with an overview on what types of jaundice would usually occur in the neonate. So the two most common ones that you need to know before you take your test would be pathologic and physiologic jaundice. Okay, now pathologic jaundice occurs within 24 hours after birth. It simply means that while the child is still in utero, there is already red blood cell destruction, and the red blood cell destruction could be related to Rh incompatibility or ABO incompatibility. So if a baby is born and within 24 hours there is jaundice, consider that pathologic jaundice. Now, usually in pathologic jaundice, the bilirubin level, okay, would be above 5 milligrams per day. Okay, the bilirubin level would be above 5 milligrams per day. That's for pathologic jaundice. Now, what about for physiologic jaundice? For physiologic jaundice, it usually occurs either on the second or the third day. Okay, then it peaks in 5 to 7 days and resolves in 14 days if you have a full-term baby and 21 days if you have a preterm baby. Okay, so therefore, what is the difference between pathologic and physiologic jaundice? The onset of the jaundice. So if the jaundice or the yellowing of the skin occurs within 24 hours after birth, pathologic. If it occurs on the second day after birth and then resolves in 14 days for full-term babies and 21 days for preterm babies, that's physiologic jaundice. Question now. What is your priority when you have a baby who is jaundice? The priority, check the age. If the child is less than 24 hours, that means you have a pathologic jaundice. If the child is more than 24 hours, that means you have a physiologic jaundice. Okay? Now, if the jaundice that's considered physiologic should have resolved by 14 to 21 days and it didn't, what could be a problem? It could be that the child is having biliary atresia. Okay? Now, there's also such a thing as breast milk jaundice. The onset of breast milk jaundice is like your physiologic jaundice. The onset is 2 to 4 days. However, the peak is longer because physiologic jaundice, it peaks from 5 to 7 days, for 5 to 7 days. For breast milk jaundice, the peak occurs between 7 to 15 days. Okay, so when a baby is jaundice, phototherapy is implemented. Now, when a child is undergoing phototherapy, it can be stopped usually for 20 to 30 minutes, okay, every 3 to 4 hours to breastfeed the baby. But if the baby is already being placed in phototherapy equipment and being prepared for exchange transfusion, that's the time that the baby should not be removed from the phototherapy equipment, under the phototherapy equipment. There has to be continuity of the treatment. Okay? Now, how will we know that phototherapy is effective? We need to check the bilirubin levels every 4 to 6 hours. Okay? Normal bilirubin level should be below 5.2 milligrams per deciliter in the first 24 hours. So, if the bilirubin levels would be above 5 in the first 24 hours, so that could mean there's gonna be pathologic jaundice. If it is below 5, then that's normal. Okay? Now, when the jaundice require treatment, when the bilirubin levels doubles than that of the normal. So when the bilirubin levels becomes 10, okay, milligrams per deciliter and above, that's the time that treatment now becomes necessary. Okay, so remember, phototherapy lowers the bilirubin levels in the blood through the photooxidation process, which simply means that bilirubin is combined with oxygen, and that is usually, that process, photooxidation, facilitates the absorption and excretion of bilirubin in the body. Okay, normalizing the levels. Otherwise, if bilirubin accumulates, it goes into the brain, so you have a condition known as kernicterus, which is jaundice of the brain. Okay, and definitely that's life-threatening. So let's try answering a sample question. Which interventions are appropriate when implementing phototherapy? Select all that apply. Position the unit no more than 30.5 centimeter from the client. Yes, it could be a range of 15 to 30.5 centimeter. So we put a check. Use opaque eye covering to cover the eyes. Yes. In fact, it is being suggested or recommended that the eye should be covered to prevent damage. Monitor vital signs every 4 hours, focusing on the temperature of the baby. Check on the temperature. Continue breastfeeding, but limited to 30 minutes to 20 minutes. Yes, you cannot take the baby out for more than 30 minutes from the phototherapy. Okay, strictly monitor fluid balance. Yes, breastfeeding is continued for infants nearing exchange. No, for infants nearing exchange transfusion, you should not take them out from the phototherapy unit. So breastfeeding is no longer indicated. They could be bottle fed but not breastfed. So we put an X. Expose as much skin surface of the infant as possible. Yes, in fact, if they are not having priapism, you can remove their nappy or their diapers. But for male babies who are having priapism, then you can cover the genitals. Okay, and frequently turn the child. Okay, now let's move on to the NCLEX QuickFix concepts as it relates to wound dehiscence versus evisceration. Okay, here's a functional concept. Surgical complications may include opening of the incision, which is referred to as dehiscence, and protrusion of the abdominal organs, which is referred to as evisceration. Okay, now the question is, what should be the priority when there is dehiscence and evisceration? First and foremost, call for help. Okay? Never attempt to reinsert the organs. Okay? Then cover the area with moist, sterile, saline soaks. Okay? So that should be moist and sterile. Then check the vital signs of the patient, making sure that the client is positioned supine to relax the abdominal muscles. Notify the physician and take note, prepare the patient for surgical intervention. So you have to facilitate the admission of the client to the operating room. Okay? So when we talk about surgical complications, sorry for those who are having their meals. I have yet to eat my lunch. Okay, I'm joining you guys. This is my mission, so that's okay. Dehiscence is when your wounds open up like this. Sorry for this, but it's the best picture I can show you so that you don't forget it. Okay. Evisceration is when the abdominal organs comes out. Okay. So which is worse? Evisceration. Okay. So this is dehiscence. Okay. You cover it with wet sterile gauze. Okay, and this is evisceration. Once again, priority, cover it with wet sterile gauze. So let's try answering a sample question. After abdominal surgery, a client experiences several episodes of vomiting. The client tells the nurse, I feel something just split open. The nurse assesses the surgical site and notes that the wound appeared like the one illustrated. So you have an opening and then you have the abdominal organ popping out. So the nurse would document this as definitely evisceration because you have the popping out of the abdominal. Now when you say gangrene, this is common in diabetic patients. Okay, dehiscence, just the opening up. Okay, but here you have the protrusion of the abdominal organ. Telescoping occurs in clients with intussusception. Okay, so what did we learn from our NCLEX QuickFix session number 13? Here's a test-taking key. Always focus on essential data and know how to reflect. Now, how do you reflect? You have to make use of our functional concepts. For you to get a copy of the 311 most commonly used functional concepts, I'm raffling, once again, 5 sets of my book. Okay? And here's the question for the Lucky Charm giveaway time. Okay, so I will make the question very, very easy for you guys. Okay, and what is the question? The question is, what is the priority of the nurse when a baby is admitted and the baby shows jaundice? What is the priority of the nurse when a baby is admitted and the baby shows jaundice? Okay, so there's jaundice in the baby, so what's your priority as a nurse? So you're given 45 seconds to send me an email now. Okay, so those of you who are sending me an email, okay, thank you for participating in our quick fix session. Okay, here's your mentor Ray saying a functional concept a day keeps your NCLEX RN fears away. And if you love this video, please don't forget to subscribe and hit the like and bell buttons. And if you share our videos to at least 3 of your friends, we're gonna pray that you're gonna pass the NCLEX with minimum number of items of 60. You'll shut down the NCLEX at a minimum number of items of 60 and pass the test. Once again, I'm Ray Gapus, your mentor, and this is my mission to enable you to pass your NCLEX RN on your first try with confidence using the functional concepts. So let's learn together. If you have some requests that you may want me to cover in my future videos, send in your requests to my email mentor.raygapus@gmail.com. Thank you very much for joining me today. I know this is too much, but for all our friends around the world who joined this YouTube live stream, I hope I was able to help you out. If you have some messages for me, please don't hesitate to send it through my email. I would personally attend to those messages immediately right after our session today. Of course, I cannot do it as I conduct the class today. But for those of you, please do send us an appreciation comment. Okay, please do send an appreciation comment in any of our YouTube videos. Please do participate and share our videos to your friends. Let's spread goodwill to everyone. We need each other at this point, and this is our way of supporting our friends to pass the NCLEX at this trying time so that we could actually take care more of our clients. So once again, this is Mentor Ray. My name is Ray Gapus. I'm an international test preparations coach and an international author of Jones and Bartlett USA, available at Barnes and Nobles. My book is available at Barnes and Nobles, and it's also available in Borders and Amazon. And of course, I know Barnes and Noble have closed shop several years ago. And of course, an author of Mostly Elsevier. Thank you so much for joining me, and I hope you had fun, and I hope you gained enough knowledge to help you out. Turn that great American dreams to reality. Mentor Ray at your service. Thank you, and see you on our next NCLEX RN Quick Fix session. Invite your friends.